Thank you very much for joining us today for this webinar. The title is quite long, but I think interesting, the long-term impact of the pandemic in the management of retinal pathologies, what we have learned and what we have changed. This webinar has been organized by the EVEG, or the Intravitreal Expert Group, which is a panel of international vitreoretinal surgeons. uh, this group was founded in 2012, and the aim of this group of friends was to improve patient care by addressing areas of unmet need for the guidance and education in the field of intravitreal intervention. We are lucky enough, and we have the pleasure to have some of the most famous European retinal experts you have seen from the program: Professor Bandello, Professor Daniel Bartelmels from Switzerland, Professor Yaki from Slovenia, Professor Antonia Jusen from Berlin in Germany, Professor Laurent Kojikian from Lyon in France, Professor Jordi Mones from Barcelona in Spain. And then we have two of my co-workers, Valentina Sarao and Daniele Veritti, obviously from Italy. Let me say a few words on these complicated, hectic times. And during this pandemic era, there have been a multitude of webinars and courses on this same topic. And I think that we are now very experts on both COVID-19 and how to deal with it in our specific field, ophthalmology and retina. Today, with this webinar, we would like to move forward because you know that the situation is rapidly changing. Although the official report by the WHO is still far from being very comforting. However, I think that after vaccination has become available, the mortality risk has greatly decreased, as well as the hospitalization, even though the number of cases are still increasing significantly in all the European countries, at least. So we should probably start at least to think on how to live an endemic time and progressively modify the limiting measures which we developed during the last 2 years. Today, we will try to focus on aspects that have been critical for the patient management, for the outcomes in retinal conditions, and we will try to avoid topics which have been extensively treated, like disinfection, social distancing, wearing masks, and other similar ones. We have heard on those and discussed too many times already. So we have those experts from different countries. We will try to address some country-specific suggestions, which will be of particular interest. We will also try to be very practical on topics such as AMD patients or DME patients, and we will try to extensively discuss those topics. So I will start this discussion by inviting a very well-known expert in Europe and in the world, Professor Bandello from Milan in Italy. Professor Bandello, can you briefly summarize the most important lessons that you have learned in the course of this pandemic, the changes you have introduced in your clinic, and also what you foresee for the near future? Can we see Professor Bandello's slides? Professor Bandello, we cannot hear you. We see the slides, but you are not online. So maybe Professor Bandello can reconnect, and in the meanwhile, I will start with the other speakers some few general questions, which I think are really quite important. As I mentioned, all over Europe, the situation is rapidly changing. So we are moving from pandemic to an endemic status. And I think all of us in our clinics are trying to understand how we should go back to the normal. In a way, we should give up many of the measures which we did introduce during the last 2 years, all the limitations we had. In other words, should we continue, for example, testing as many patients as possible for identifying the COVID-19 positive patients, or should we focus only on symptomatic patients and remove all the limitations to access to our care for the patients who are asymptomatic? Daniel, how are you foreseeing in the next future with dealing with patients and with testing for COVID-19?
Well, you maybe have heard that in Switzerland we actually didn't do so much testing. There was testing for inpatients to reduce infections when patients are hospitalized, but for outpatients, such as the medical retina patients that are treated for AMD or DME or RVO, were not tested at all. So we require now, since vaccinations are widely used and available, that patients should have a vaccination certificate, and we encourage them for getting a test if they're not vaccinated for whatever reason, but we don't force tests upon everyone. We haven't had huge issues with that. We could run the clinics rather smoothly. It depends also a bit on the environment, about test availability, people willing to test, and there is also a financial aspect to that. If you look at the magnitude of patients that have to be tested and the impacts it has on the clinical routine, missing out appointments and so on. So given the current developments, I may be inclined to say that we could reduce the testing to those that are symptomatic, in order to focus really on those that might have an issue. But for the rest, when the vast majority is vaccinated, I don't think that we would
Yeah,
actually have to
yeah.
test.
I fully agree, Daniel. This is very reasonable, and this is how we managed during the pandemic times. All outpatient patients were not
Mm.
tested, and this allowed us to treat as many patients as possible with intravitreal injections. So on one side, we were missing those who were COVID-19 positive, but on the other side, we were able to give the injections to as many patients as possible without any delay. Bologna, can you tell us how you deal with the same situation?
You know, in Slovenia, the testing is not obligatory, but to enter the hospital, you have to have one of three conditions. Either you are vaccinated, either you had recovered from COVID. If you are not, if you don't have any of those two conditions, then you have to be tested. That is for the outpatients. But only for those who come in the hospital to spend the night in the hospital, those need to be tested. But for all outpatient clinics, one of those three conditions is obligatory. So we don't require obligatory testing. But as the number of infection in Slovenia is now very high, we also run late from the result of tests. So it's really questionable whether the tests are doing their role, you know, if you get the result too late. But for the patients that come to the hospital, I think that we managed quite well in this way, that one of those three conditions had to be fulfilled, not obligatory testing.
Okay. And Jordi, how you manage the patient coming to your clinic?
Yeah, not many differently than what it's been said. And we have to remember that in clinic, we all wear masks, patients and us. So the risk of infection is very low. And actually, probably where people get infected is when having lunch or drinking or being with young kids. Nowadays in Spain, the most source of COVID are children. So if you wear a mask, the likelihood of getting infected is probably very low. So now with that, we have more than 80% people vaccinated. In the elderly, probably it's more than that. And also, Omicron is so expensive, it makes no sense to test asymptomatic people. It would be, you should be testing every day. It's out of sense. So only people with symptoms are tested. And we haven't had any outbreak in the clinic, even with the personnel, even with the patients, even in the worst times. So I'm I would say that the risk is when people do things that they do not wear masks, like going to a restaurant, having drinks, or having family dinners or lunches, Christmas, so on. So I think at the clinic we are quite protected, and I don't think we should be worried of testing people if they're asymptomatic.
So before we move forward, Antonia, I'm coming to you.
Yeah.
There
Yeah.
is up to now a kind of a consensus, at least for those outpatient patients who need intravitreal therapies or monitoring. And there is a consensus on the point that at least from now on, but also in the past, extensive testing is not needed unless a patient is symptomatic. So
And,
this is
and
a big change on
But
the limitations. But I want to come to Antonia and hear how
yeah,
you
just
behave and your thoughts in Germany.
just a very different opinion from our hospital's administration. So we do believe exactly the same. We want less testing, and we think it's ridiculous that these elderly patients, and especially the accompanying persons, cannot come to the hospital. And this makes a huge problem because these old and not seeing patients have to come alone. They are nearly blind. They don't even find basically the hospital. And since we had a small outbreak of COVID in my team last week, we have to be tested. Everyone has to be tested daily. And
Wow.
this doesn't make any sense at all. But
Wow.
it's a hospital's requirement with the quick tests. We have to do daily testing with the PCR testing twice a week. And well, I think
Okay.
it doesn't really
uh,
make sense.
Great, Antonia. Laurent, yes.
yes, yes, I do agree with Antonia. I agree also with you, Paolo. We have a consensus to say that. Nevertheless, we have to deal with the official rules and the legal rules. And now, in France, we have the vaccination certificate is mandatory. So there is a vaccination pass. And so, for example, for outpatients, if they are vaccinated, we do not have to test outpatient. But if they are not vaccinated, we have to test it. And this is the rule. Even if I'm convinced that if they are asymptomatic, I do not have to do it. But it's a rule.
Yes, Laurent, I think the big difference is in between, first of all, asymptomatic patients or symptomatic patients, and in most of cases we are dealing with an age population. So if they have the severe form of the disease, they have some symptoms. And as you mentioned, vaccination may make a big difference because in most of cases vaccinated patients might be positive, but they have many times they are asymptomatic, and there maybe that their infectious properties are lower than non-vaccinated patients. But Jordi, you wanted to say something on this?
Yes, nowadays in my region, the certificate has been not. It's not anymore obligatory because with the Omicron, it's been known that it does not prevent from spreading the virus. What it does is to prevent hospitalization, prevents intensive care unit and deaths a lot. So the authorities want to push the promotion of vaccination for that reason. but not anymore to prevent contagious. Makes no difference. So vaccinated people can transmit COVID with this Omicron as anyone else. So it's probably at this time the certificate. It's good to force people to get vaccinated, not to get into the intensive care unit and not to make a tremendous burden on the system, but it's not good for preventing spread of it. So
Yeah, yeah, Jordi, I think you're fully right, because what we are seeing is that the number of infected people, either symptomatic or asymptomatic, obviously depending on how much you test, is rapidly increasing in Italy and all over Europe. But luckily enough, after vaccination, the number of severe forms which need hospitalization or intensive care is decreasing. And most of all, the risk, the death risk due to the disease is going so down, which we didn't see for a couple of years now. And now the death risk is really, really has really changed as compared to 1 year ago, for example. Daniel, do you want to show your thoughts on
Yes.
what your experience and on Switzerland?
Can you see the slides?
Yes.
yes, we do.
Okay, good. So there are just two papers from our department. So the lower one, assessment of patients' confidence regarding a new triage concept in medical retina clinic during the first COVID-19 outbreak, is a paper that was published by a group here. Sandrine Zweifel, most of you know, led this group and study. So when COVID was on the rise, we thought about how we can deal with the high patient load and the restrictions and risks imposed by the pandemic. And what we did is we actually froze literally the intervals. Most of our patients are on a treat and extend regimen. And we thought that if we freeze the interval patients are on and do not extend or shorten, we run in some patients the risk that they may have a bit of an overtreatment because we could extend them. Given the intervals we had, we would have a very low risk of under-treating patients because they would actually need shorter intervals. And by freezing the intervals, we could shorten the time the patients spent in the clinic. We also asked patients over the phone whether they have experienced changes in their vision and could establish this triage concept that Sandrine and Anahita nicely described in their paper. And that helped us to get through this pandemic. Now, the results of that management are published as part of an international publication with colleagues from Spain, France, the Netherlands, Ireland, and Australia and New Zealand. That's the paper in Retina from Javier Saranz Ventura. And what we found is using this triage concept, we had actually more or less stable vision in the patients with neovascular AMD. So when we compared the visual acuity just before the pandemic started in each eye to the visual acuity following that first pandemic 6 months after this lockdown, so we had really severe restrictions. In patients with DME, we found a 2.5 letter loss compared to the start of the lockdown. We attributed this to the reduced number of injections. And what was very important, a very important finding was that the main loss occurred in eyes with actually good vision, that is 70 or more letters. The same, but a bit less pronounced, was found in patients with retinal vein occlusions. They had about a 1 letter loss compared to the start of the lockdown, and they had on average 1 injection less than in the 6 months prior to the lockdown. And also here, the vast majority of eyes losing vision was the eyes with actually a good visual acuity to start with. So when we found these results, we thought that, okay, it's maybe important to have a good strategy to triage patients, but we also have to look specifically at those with a good visual acuity, because those tend to be the ones that suffer most. The other effect or important learning was that we have to pay attention to those patients with diabetes in particular, because they seem to fall through the net. We also had reports from other departments, neurology, endocrinology, where we could see that those patients who have a plethora of other problems seem to take quite a bit of a burn from these pandemic conditions.
Thank you, Daniel. We will come back on those differences in AMD patients and DME patients that you are suggesting. Let me ask you something. You were mentioning freezing the interval between injections. Does it mean that you move from a treat and extend, which you have proven to be very effective in normal times, to a kind of a fixed interval?
Yes. So if patients, for instance, were in a, we were extending them like 4 weeks, and then we could go to 6 weeks, and then the pandemic started, we would just keep them at 6 weeks and not extending further. Or if they were already on an 8 or 12-week interval or 10 weeks, we would just keep them there and inject them. What happened during this special triage was that patients did not have a detailed exam before the injection, which is something that is required in Switzerland. We just would do an OCT scan to see what the retina looked like and give them the injection to make the time in the clinic as short as possible. Visual symptoms were collected over the phone later on, but that's not as precise as actually taking visual acuity.
Okay, great. Laurent.
Yes, what we're speaking about is about the first lockdown in France, like many other countries. I think it was in March and April 2020. I was president of the French Society of Ophthalmology during this period, and we edited some guidelines for all the French ophthalmologists. And so most of patients were converted to fixed regimen, to, like you said, Daniel, to reduce exposure time in the clinic. And so we said no mandatory ophthalmologic examination like slit lamp or fundus, no CT imaging during March and April 2020 before the injection if the patient didn't report any new symptom. And so we fixed a fixed interval, of course, and we favor also bilateral injection. But this was during only the first lockdown. During the second, the third, and now we have the fifth wave of epidemic. It's completely different because we have all our patients in our clinics for the medical part of our job. Of course, we have a reduction in surgery, but not not in the consultation, and so we do not have any more need to change the regimen of treatment, I think.
Good. So you're right. You are highlighting that we are dealing with a pandemic which has been lasting for 2 years. So during the first wave, the pressure with COVID was massive, and progressively everything has been changing. And now there was this sort of consensus a few minutes ago from all of you, from all of us, that we should gradually remove all the limitations and go back to the normality. Thank you, Laurent, and thank you, Daniel. We will come back on specific patients, AMD patients and DME patients, but because as Daniel mentioned, DME patients might be more complicated in their holistic management, which needs the intervention of the diabetologists and other specialists. Polona, can you tell us something on your Slovenian experience, some tips?
We learned during this time of pandemic that it's very important to be flexible in management, because this flexibility actually increased the efficiency. In the beginning, when the first lockdown was, we also had so-called freezing way of intervals in between injections. But at the beginning, we just injected because we believed at that time that the pandemic won't last so long. But after a few months, we realized that just injecting definitely is not what we want to do. So we added OCT, and then later on, we had some visual acuity. Actually, we adjusted the approach, the approach to the patients according to the restrictions or according to the wave, the point of the wave, the amount of infected people in the population. And we always, all the time, we had to balance between the risk of vision loss and risk of infection. So when there was a high wave, we quit all the, for example, screening for diabetic retinopathy. But later on, when the situation became better, we introduced the screening once again. But also we realized that during the pandemic, we didn't communicate with patients as much or as they were used to be. And that mask and limited time in the outpatient clinic, of course, reduced the amount of communication. So we made these informative brochures for patients to inform them about the disease, about the treatment, and then we wrote also the letter for the patient to explain them how the treatment is adjusted to the current situation, what was important for those who were treated before. And then that made communications easier. So also the relatives or accompanying person know what will be going on with the patient. And then we also figured out that it's very important to give the patient the printer report the same time, the same day when they leave the hospital, to have written next appointment. And in the time of pandemic, we introduced also the volunteer students. They mainly helped at the entrance, where the patients had to be checked, their certificate or their health status, and that the patient really came into the hospital the time that they were scheduled. And those students also explained the situation to the patients, and they really were very efficient and very good help for the time for the management with the patients. But I think that now, when the number of vaccinated patients is increased, this pressure about the fear, about the tension about being infected or transmit the infection is much more reduced than before vaccination or at the beginning of the pandemics. But we learned in this time that it's really important that injections, intravitreal injections are prioritized. That means that that patients are regularly injected, that they are encouraged to come just to avoid the irreversible damage. And we made some changes that I think that are good one, and that will go on after pandemics become endemic. They will go on as well. For example, in my hospital, we have for retina patients, we have so-called diagnostic clinic and treatment clinic. And in diagnostic clinic, all multimodal imaging is done, and we used to do this one day and then schedule patients for the injections. But due to pandemic, due to reduce the number of visits, now we started to inject the same day as the baseline diagnostic was done. And we worked a lot in reducing the waiting time in the waiting time in the waiting room, to reduce the number of patients in the waiting room with precise scheduling. And I think that was done fine, and that is one of those things which should be followed also later after pandemic. And we also think about slightly adjust the approach to the anti-VEGF patients. we realized that OCT is obligatory to follow treat and extend regimen, and that visual acuity is not so crucial for every single visit. We now are performing visual acuity every 3 to 4 months. That means 3 to 4 times per year for majority of patients, AMD mainly. And it seems it works fine because visual acuity is very time consuming, especially due to DRS. And we think it doesn't give you so much information that our decision about the intervals of the treatment does not relate so much onto visual acuity than OCT. So this adjustment perhaps will be followed also in the future.
Polona, I just have a quick question. If you go back by one slide, if possible. No, okay, but it's fine. Okay. Yes, you have introduced something which is quite original. You mentioned this balance in between the risk of vision loss, probably independently from the condition, either AMD or DME, and the risk of infection, which is also related to the age of the patient, the health status. And when you say risk of infection, I think the severe forms of COVID-19, which you want to avoid in your clinic. Did you develop any algorithm, a formal algorithm for that, or this was done on a case-by-case situation? Because this is very interesting, single eye versus those, the first eye involved, good vision versus poor vision, the age of the patient, the health status. Did you develop any algorithm for that or not?
Actually, it was not so precise algorithm because it was individual approach. We went through the patient's file to see whether this is the better eye which is treated, what was the development of his and the effect of the treatment, and what is the general condition of the patient. And the base of this, we communicate with patients and talk with him just to figure out whether it's really necessary to come in the first part, on the first step of the pandemic, when we were not so protected as we are now. And of course, when the load of pandemic, I mean the spread of virus was reduced, we opened more the door. I mean, we invited more the patients to come. Also those who were, for example, in higher risk for getting systemic damage compared to the before. Before we were inviting more those who were in the bigger risk to lose their vision.
Thank you, Polona. If there are not any other comments on the Slovenian scenario, I would move to the German scenario and then the Berlin scenario with Antonia.
Maybe one
yes.
comment. Maybe one comment, but maybe you want to discuss later. I don't know. It's about the future. In fact, what I mean is about the no need to measure visual acuity at each visit. Do you want to discuss it now, Paolo, or more later?
Oh, we can do it now, I think.
Okay, I do agree with you, Polona, as I don't think that visual acuity measurement is really mandatory for each visit. And an OCT and probably a retinal photography without a dilated fundus exam could be enough to follow our patients, especially our AMD patients. And of course, we need to do a slit lamp examination maybe every 6 months, or if the patient feels something wrong, etc. But nevertheless, we can win time and we can be more efficient without doing visual acuity measurement and dilated fundus exam.
Yeah, this is definitely very reasonable. I mean, trying to take out from the flow everything which is not really needed. And after all, what is really needed in those patients, we know that, is the injection, the regular injection. Visual acuity measurement is not necessary, as well as OCT. Jordi, and then Daniel.
Yes, I think that there have been three times here. The first 2 months where we were locked down, and that was a very savage time, 1,000 people dying every day in the country. So there we were doing some triage, meaning that I was reviewing the charts individually, and I extended 1 or 2 weeks maximum to save those 2 months. Those were those were not the most complicated because every other patient were not coming to the office, so we were prioritizing AMD. The second period, the second part was that time that we were away from the first wave, but we still had no vaccines, and we had to move on, and we had to treat patients pretty normal. And in that period, I think that applies very well, all these measures of not doing unnecessary things like visual acuity and not performing excessive tests, because at that time, we could not do triage anymore. We can do triage for 1 or 2 months, but we cannot extend that a long time. But now, where patients are, we are in the third part, and patients are vaccinated, everyone is vaccinated, most of everyone. So now, we should behave normal related to COVID. If because your hospital has a lot of burden and it's not feasible to provide treatment everyone because you have to measure visual acuity, that's fine. But that's because of the burden, probably not anymore for COVID. So COVID should not be at this time a reason for doing all the kind of things. It's great to do it if you want to optimize your system and your burden, but it's not anymore for COVID. Now we should behave pretty normal. I would say behave pretty normal, but the mask, because since we treat very old people, even they are vaccinated, we will keep our mask long time because there is a small percentage of vaccinated old people that can get that disease. So we probably will not get rid of the mask for a long time. That's very true. But besides that, I would make a strong commitment of behave normal, or at least behave what is the best for our patients and not considering COVID anymore. I don't think it's necessary now because I don't want to do any kind of deal with COVID that makes our care less optimal. It's difficult enough already to make any kind of commitment because of COVID.
Daniel, thank you, Jordi. Daniel.
Yeah, I just have a quick comment regarding Polona's statement, taking visual acuity only every 3 months. I think with the advent of algorithms that help us to understand OCT's images better, there will be actually an opportunity to move away more from the individual assessment of OCT images and the assessment of visual acuity when it comes to treating patients. So I think there is a point, and your exercise you did during COVID pandemic can show that very well, that you can achieve reasonable results when you just look at the images and when you treat. The important thing is the treatment. And then every now and then have a look at the visual acuity. I mean, there needs to be some interaction with the patient. You need to understand where we are. The patient wants to know what is my visual acuity. There is an internal need also for discussion. But regarding the treatment, I think there may be a time when it's not necessary, just from a purely treatment point of view, to take visual acuity at every single appointment.
Yeah, yes. Antonia, Polona, we move to Antonia, then we go back to you and for some more discussion. Antonia, we want to hear from Germany.
Yeah, so I would personally agree with Jordi. However, there are these hospital problems and administrative problems in Germany. We still have, every patient has to be tested despite they are vaccinated, and all the accompanying persons, as I discussed before, they have to show a fresh test not older than 24 hours, and that makes up most of our problem. So what we did is 2 years ago, we started to have almost all patients on treat and extend. That helps us to reduce number of patients, and this is irrespective of the pandemic. We have increasing patient numbers in any case, and we have to limit our injections. Injections have been possible throughout the whole pandemic and have not been limited in numbers, but the access of the patient is a problem. And this is why at current we are trying to go beyond our contracts with the insurance companies. The insurance companies have made these arrangements that we use a certain quote of Avastin. I think Avastin, given the COVID pandemic, is not the appropriate drug to use. We need to have some more long-standing, long-acting drugs, and this is why we are currently fighting to get more patients into, for example, Eylea, and then have them on top on treat and extend. Yeah, in my clinics, I have the patients usually come for their injections, and I see them only every second time before and then do the visual acuity assessment and so on. So I wouldn't do that every time. I would agree with Polona that we can probably, if we stay within a certain extension time, we are safe if we do the visual acuity and so on only every second time. But I have to admit, we have seen a couple of more patients with hemorrhages than we did before.
But I have a question to everybody. Obviously, if we are using a treat and extend regimen, we probably have to check the patient at least with the OCT and probably with visual acuity in order to establish the next, the interval time and the next injection. But independently from that, do you think that in this endemic time or going back to normality, shall we expose the patient to less visual acuity examination, less OCT exams during the course of treatment or not? Laurent, what do you think?
I think that when you have to decide for an AMD patient if you have to retreat or not, are you really going to use visual acuity? Don't you think that the retreatment criteria are more anatomical?
Yeah,
and
sure.
so I think that OCT enough is enough to check. You need a retinal photography to see if there is new hemorrhages or not. You have to see if there is fluid or not. Which fluid do you want to treat or not? It's another debate. But visual acuity does not really change my decision. So as for me, I'm sorry, Antonia?
I would think this is very true. The problem is only some of the insurance contracts require to have a visual acuity assessment on top of the OCT. This is like for the first visit, every patient has to have an angiogram. Well, I think at some point it's very clear if it's a wet AMD, and I'm not so sure whether every patient really requires this.
I understand it's a difference between France and Germany, because we don't have this need and this request in France. Nevertheless, to be honest with you, I go on to measure. I go on measuring my visual acuity as I need visual acuity for my clinical trials, for my next papers, etc. So I continue to do it. But if I was in a private practice, I'm not sure that I will continue to measure visual acuity at each visit, each assessment.
But there's also something the patient wants to know it. For a patient, visual acuity is important.
Yeah, that's true. That's true. That's true.
I agree.
You're right. You're right. Laurent, do you have any slides?
I'm sorry?
Do you have any slides to present?
No, I do not have any slides.
Okay,
no.
So I think we can go on with the discussion, and we can let Daniele show some slides, and we will have some discussion on what he's showing then.
Okay. I hope you can see my slides.
Yes.
Is it okay? Great. Good evening. The prevalence of blindness due to AMD declined by almost 30% from 1990 to 2020, and this decrease is likely due to the widespread use of anti-VEGF therapy. Here you can see how several countries recorded a rapid decline in the incidence, studying the new cases of blindness. And the current widespread use of anti-VEGF therapy for the treatment of a number of ocular conditions such as AMD has the potential to decrease the prevalence of blindness and visual impairment, but if it used in the correct way. And despite the significant progresses in the cure of AMD, some countries may not experience improved outcomes, as shown by the AURA study. I'm going to focus on the Italian situation. And as you can see, there were substantial differences in visual outcomes and injection frequency between countries. Italy had the lowest mean number of injections over 2 years. It was 5.2. And as the pandemic raged, the situation got even worse. In this study, the number of eye surgical procedures performed in Italy during the 2 months of following the beginning of the lockdown was compared with the 2 earlier months and to the same period of the previous year. Due to government rules, during the lockdown period, eye surgical procedures were limited to urgent procedures, and intravitreal injections, as you can see here, dropped by approximately 50%. There was a high variability among different ophthalmic centers. Some centers lost only about 10% of the planned intravitreal therapies, just like our center, mainly because patients refused to travel to the hospital because of fear of infection. Instead, other centers completely stopped administering intravitreal injections because of resource and personal shortages. And the COVID-19 pandemic has been a sort of stress test of huge proportion for the Italian social services. And from this data, you can see how it influenced the treatment of retinal conditions. Data on drug consumption in Italy for ocular diseases, including glaucoma, and are displayed in green, whereas just anti-VEGFs are displayed in blue. And these data are quite eloquent. As you can see, although intravitreal therapies have become the gold standard therapy for various retinal diseases, during the last years, the consumption has remained surprisingly stable. And the mean number of anti-VEGF injections given during the first year of therapy is still very low. And we know that more frequent injections are associated with greater improvements in visual acuity. We believe that many reasons may have contributed to this scenario. First, PRN regimens are still widely used in Italy. Instead, we know that a fixed or a treat and extend regimen is the best approach to wet AMD patients. This is an easy to solve problem, in my opinion. We just need to better spread guidelines coming from clinical evidence. And the second problem is more difficult to solve, and it needs a concerted effort, as our healthcare system wasn't reorganized to improve clinic efficiencies after the introduction of intravitreal agents. Several models have been tested in other countries, leading to improved efficiency and screening campaigns and intravitreal therapies. And other problems that we have is that Italy was one of the first countries to offer reimbursed off-label bevacizumab, but it was not sufficient to improve the efficacy and efficiency of the system. For example, we have obsolete regulations. And this is a problem here. Intravitreal agents must be administered inside hospitals or comparable facilities. However, no one from the health authorities has defined yet what a comparable facility is. Moreover, only highly specialized hospitals who have been appointed by the regions are authorized to dispense anti-VEGFs, while we know that intravitreal agents can be given in an efficient and safe way in an extra hospital environment. And I think that a position from the retina community and the Retina regarding the appropriate setting for giving intravitreal injections could help us very much in overcoming this impasse. Thank you.
Thank you, Daniele. Thank you for showing this dramatic scenario in our country, which is not unreal. Unfortunately, this is reality. Before we move on to some further discussion, I just want to remember the audience that you can send specific questions to the panel via the chat button. And we do have one question from a guest. He's mentioning a specific situation, and I am addressing this question to you all in order to understand if anything like that did happen in your clinic. So he's mentioning some patients who come in for the intravitreal injections. Patients are masked, the injecting physician is masked, but he's asking if any cases in which the patient was infected by the injecting physicians did happen in your clinics or not? Jordi, did you have any?
No, but I want to make a comment because I have to leave. I have another call on 7.
Yeah.
So
Yeah, sure.
I never had one. I think that's not very likely because when both people wear masks, that's very unlikely. I haven't had anyone. So, but what I wanted to say is, according to what Danielle was saying, the main problem of wet AMD is under treatment, and this is not COVID. This has been for many years. It's a shame. 3 out of 4 patients in the world are undertreated. And the prevention of blindness by models should be 75% and not 50%. So we are losing 25% of people. So maybe we'll be grateful to COVID because COVID has made systems to be more efficient, to make patients to be less in the clinic. So maybe, thanks God, COVID at least will have a positive thing, which is make systems more efficacious, and then maybe the other treatment will be less from now on. So hopefully COVID has been useful for something. And it could be because now, as Paulona said and Lauren, we are able to treat patients with much less testing. And you have to avoid something is everything else by injections. Saying hello, taking vision, taking even OCTs. If you force me, if you're so pushed by burden, three injections in a row and don't look, but keep injecting because these 3 point something numbers that Danielle was telling, they're very sad.
Sure.
We know less than 7 first year, it's very sad. So this shouldn't happen. And hopefully from now on, things will be much better. And I'm very sorry I need to leave. Thank you so much.
Thank you very much, Jordi. Thank you a lot.
Bye, Jordi.
For your contribution. Thank you. And yes, I think this is the bigger limitations, the insufficiency of treatment, of course, as Jordi said, and as Daniele has been showing. As regards the Italian scenario, we have these big limitations, which is, as Daniele said, that injections should be performed in a hospital, and we are not officially allowed to inject outside the hospital. This is really dramatic because access to therapy becomes very difficult for patients, especially in the COVID-19 times in which patients do not want to come to the hospital. And I hope this will rapidly change. This silly regulation will change in Italy. I have a specific question which might be stupid, but I think it's quite important. We have underlined the importance of still wearing mask, face mask. However, there are some reports which underline that patients wearing a face mask during the injection itself might raise the risk of endophthalmitis after the injection. So what I've been doing is that a patient comes in the hospital or in the clinic, they wear the mask as well the physicians, but soon before the injections, we do remove the mask, we do the injections, and then the patient wears back the mask. What's your attitude? You keep the mask on the patient while injecting, or you remove the mask?
We keep the mask.
We keep the mask on.
But we
Sorry, Laurent.
Sorry, Daniel. As for me, we keep the mask, but we put the mask under the nose, because I think that there is a higher risk of endophthalmitis, because there is I don't know really the English word, but the flu
Yes.
near the nose, in fact, in direct towards the eyes. And so if you put the masks just under the nose, you will not have this, I think.
Yes.
Daniel?
Yeah, Daniel?
Yeah, we also keep the masks. I mean, we have to drape our patients with a sterile drape where mouth and nose are covered anyway, so it doesn't really make a difference, but we keep the masks on, and we didn't have cases of endophthalmitis.
Okay, so you drape all the patients. Okay.
Yes, so the face up until here.
Yeah, exactly. Polona, you keep the mask on the patient?
Yes, actually, we change the mask for the patient when they come into the hospital, but we drape them in the upper part, and when injecting, we don't drape, but we just cover. That means the whole of the eye is open, so the air would be able to go through the eye. That's why we tape the upper part of the mask, and so far we didn't have any increased number of endophthalmitis at all.
Antonia?
Yeah, same for us.
Okay. So I think we have some few more minutes. I would ask Valentina to show some of her thoughts related to the Italian scenario. And then I would like to discuss more specifically on patients with AMD and DME.
Good evening. Can you see my slides?
Yes.
Perfect. Good evening, everyone. In the next few minutes, I would like to show you the latest news about COVID pandemic in ophthalmology. I conducted a literature review with the aim to discover for you 10 pairs of particular interest for retinal physicians. Let's start with the first one. Is the SARS-CoV-2 virus present in human retina? The answer is yes, it is. After the initial infection in the respiratory system, we know that the virus can spread throughout the whole body, reaching different tissues and organs. Recently, researchers from Brazil have found that SARS-CoV-2 viral particles may reach many layers of the human retina. The results may help clarify the pathophysiologic mechanism of SARS-CoV-2 and improve our understanding of the consequences of COVID-19. The study results may also direct avenues of future research to determine whether the ocular manifestations of COVID-19 are due to direct viral invasion or occur as a result of the microvascular or immunological changes of the virus. The presence of the COVID in the retina is also confirmed by this observational study in which COVID-19 patients showed a mixed pattern of hyper and hypo-autofluorescence. These findings were seen close to vascular structures in different retinal areas. Additional trials, obviously, are needed to better understand the retinal long-term implications. In 2017, Luxturna was the first FDA-approved genetic treatment for Leber congenital amaurosis and, in some cases, retinitis pigmentosa. Now, a gene-based vaccine related to Luxturna could be a weapon in the war against the coronavirus. This novel vaccine delivers genetic sequences of the SARS-CoV-2 spike protein using an adeno-associated virus vector, following a low-dose intramuscular injection. Human trials are expected to start later this year, but some interesting results already have been conducted on monkeys. Genome editing using CRISPR technology has a great potential in the treatment of various diseases. Lately, this technology has taken a step forward because it is one of the candidates for the realization of a gene editing therapy aimed at limiting the replication and mutational escape of SARS-CoV-2. This same technology aimed at editing human DNA is also one of the promising options for the ongoing gene editing of Leber congenital amaurosis. Pearl number 5. As all known, the use of face masks while visiting our patient may hinder the visibility of the retina. Here I report some methods that can help keeping glasses and diagnostic lenses fog-free, even when patient and retinal physician are wearing a face mask. Among these tricks, I reported an anti-fog technique described by some authors that you can use during the everyday clinical practice. While holding the lens with the first and the second finger, create a pressure over the upper edge of the mask against the patient's cheekbone with the annular and pinking finger. This avoids that warm breath escapes from the top of our patient's mask, avoiding fogging over the lens. During the COVID-19 crisis, telemedicine has allowed retinal specialists in various practice environments to remotely perform follow-up visits and consultations. Here I would like to show the first treatment at distance using the online 5G real-time navigated retinal laser photocoagulation to treat successfully a patient affected by diabetic retinopathy. Some case reports have been published reporting ocular adverse effects after COVID-19 vaccinations. This includes facial nerve palsy, vascular occlusion, and uveitis. It is important to note that the benefits of receiving the vaccine far outweigh the rare ocular risks. These side effects are similar to ocular manifestation due to COVID-19 infection, as we reported recently, so there may be a common pathway between the immune-mediated response to the vaccine and the virus itself. Pearl number 9. A significantly higher possibility of viral transmission exists through tears in patients with moderate to severe COVID-19. Therefore, according to this study, the respiratory tract is not the only transmission route, and a notable viral shedding occurs in the precorneal tear film in patients with COVID, implying that besides face masks, use of goggles and face shields by ophthalmologists should be mandatory when interacting with patients to reduce the transmission of the disease. This is the last pearl. Using the MRI, radiologists are seeing significant optical abnormalities in patients who have suffered severe viral disease. In this slide, we can see the ocular MRI findings in patients affected with severe COVID-19, consisting of the presence of nodules of the posterior pole of the globe. Although the cause is not known, the authors of this study said that these findings point to the need to screen patients with severe COVID-19 to detect any potential ocular abnormalities. Thank you.
Thank you, Valentina. This was quite interesting, and I have a questions from the audience, which specifically refers to slide number 1, which you showed, per number 1, in which you say that COVID-19, the virus penetrates the retina, and maybe it makes something into the retina. So this question from Dr. Ami asks whether you have seen more diabetic retinopathies or more worsening of diabetic retinopathy during the COVID-19 pandemic. And if you believe that this is due to the limitations in seeing patients, to the changes in the metabolic control, or I'm suggesting, after seeing Valentina's slides, in possible interactions in between the virus, the retina, and diabetic retinopathy itself. Laurent, what do you think?
Sorry, I was on mute. It's not easy to answer. I think it's really depending on the different centers, on the use you have, the different countries, etc. As for me, we didn't see diabetic patients only during 2 to 3 months, not more, because during the first wave, the first lockdown, then we continued to see these patients. So finally, at the end, I didn't see any severe patients. It was different from AMD patients. For AMD patient, we see some patient with a big hemorrhage, with hematoma, and so with lost vision. But for DME patient, it was okay. And for patients with severe diabetic retinopathy, now it's rarer than before. So it was not a real issue for us, diabetic patients.
Thank you, Laurent. Antonia, what did you observe in diabetic patients? No.
You repeat once.
Yes, Antonia,
Yes.
what did you observe on diabetic patients? Did you see any worsening of the diabetic retinopathy? Did you see more patients with diabetic retinopathy, or no big changes?
No, in fact, we didn't. I think if at all, we saw a problem initially with the AMD patients because that was the age group that didn't dare to come to the hospitals. So we had some hemorrhages and so on, and some progressions for patients that wouldn't appear to their appointments. But in the diabetics, I think there was no increase. However, we are trying to, for the periphery, we are continuing laser treatment, and we give the advice to the patients that injections for proliferative retinopathies aren't probably, well, this is my general opinion, are not really the first choice. I would always think it is much easier and better to have a one-time laser treatment if it's done appropriately and towards the periphery. I think this is the safest way of maintaining the patient's vision. And this is what we have proposed also to our to all the referral doctors, that we would advise to continue with the laser treatments.
Yeah, thank you, Antonia. This is very important because, you know, we have the possibility to use anti-VEGF, but we have to balance, especially during these COVID-19 times, the risk of progression. Yeah.
Yeah, but the problem is in these proliferative diabetics, you need to really take care for them in a very continuous manner, and you're not really sure whether they're coming or whether they have reasons, COVID-like reasons for not appearing. Yeah.
Sure, Daniele.
Yeah, I just want to add a brief comment. There is some evidence that SARS-CoV virus can directly increase diabetic neuropathy. There is some histologic-based evidence that the virus can increase diabetic neuropathy. Yeah, so it may be also a direct action.
Sure. So this is a good answer to Dr. Amy regarding the question which was posed before. We have another question from the audience, which is initially addressed to Valentina and obviously to the others. And I want to see your opinion. Dr. Fabienne is asking if you have ever seen any signs of retinal changes, obviously secondary to COVID-19, at the OCT level in the patients we are seeing.
In literature, there are very few evidence about alteration or retinal modification on OCT, on V-scan OCT. I do not found so many evidence about that.
Yeah, I haven't seen any specific changes in our patients. Antonia?
We have seen some patients that presented after a severe COVID episode during the first 2 years of the pandemic. So patients that had been intubated, and these patients presented with obviously post-viral retinopathy, acute retina necrosis. There were 3 of these patients, but obviously it's not necessarily COVID. It can also be some associated other infections. But I thought it was interesting. We tried to isolate COVID from these rotten retina. It didn't work out. So there's no proof. I think it could be as well a secondary infection with herpes or any of these viruses.
Yes, obviously, Antonia, this is very interesting. But as you mentioned, those patients who were in intensive care, intubated, they were really plenty of other infections, lung infections, both viral or also fungi infections. Yes, thank you. Polona, can you tell us something on this OCT pattern after COVID-19? If you have
yes, actually, we performed the clinical study in COVID department, where we recorded OCT and OCTA for the patients in the COVID, with acute COVID. And we wanted to see whether there are the changes which were described to be in the retinal vessels, in the retina, are really due to COVID or due to other diseases. So we excluded those patients who had diabetes, who had hypertension, or who had high level of lipids. And we recorded those images and then analyzed them. And what we found out is that there were some changes also in the level of OCTA for those who had more severe COVID. The article is not yet published, but it's sent for publication. We'll hope will be published because the results are really interesting.
This is very interesting. Let's go back to diabetic patients, because we have already focused on AMD patients with the different regimen, visual acuity measurement, going to fixed regimens or to the last effective interval. But let's talk a little bit more on patients with diabetic retinopathy, which are more complicated, as was suggested at the very beginning, because it's a systemic disease. Can you briefly tell the audience whether you change anything during the pandemic, and you will keep those changes after the pandemic when you manage and treat diabetic patients with diabetic retinopathy? We start from Antonia. Antonia, some tips.
Well, I think, as we discussed for the AMD patients, I would also go for something like a treat and extend regimen. I would try to use agents that are more long-lasting. So for me, it would be preferably aflibercept. I would keep the initial so-called uploading phase, in which I wouldn't do very detailed exams in between. So this means the first 5 or 6, even 6 injections, as recommended by our German Ophthalmological Society, should be done in 4 weekly injections, and I would just proceed with these without having the patient for a detailed assessment in between. And so everything can be rather nicely planned ahead, and the patient has a very reliable schedule. And as I said, for all the patients with proliferative disease, I think there's a very good option that we can stop these proliferations by a PRP. And I always put the emphasis on the periphery, and
Yeah, I think this is very important. As you said, patients with proliferative diabetic retinopathy have a high risk for progression if not treated. And if they have no access to regular anti-VEGF injection, obviously this risk is consistent. So we should refer back to the efficacy of scatter laser photocoagulation. This is very important. Laurent, what comes from your side on diabetic patients?
From our side, the ophthalmologic side, I would say that we did not really change anything except for the first lockdown. Now, from the patient side, I would say that COVID-19 could explain the fact that they are not coming sometimes. They are afraid. They think that they have a risk to have infection. And so sometimes they are not coming. So from our side, we didn't change. From patient side, we need to see them.
Polona, how will you manage diabetic patients as compared to the pandemic times? Anything you have learned and you will keep in your behavior, or nothing did change and nothing will change in the future?
Okay, despite what was already said, it's not much to add. Only what we changed during the pandemic is that for the patients, diabetic retinopathy patients who are not treated yet, but just in diabetic retinopathy patients clinic, we introduced somehow the virtual clinic, or how would you say, the patient come, we measured visual acuity, perform OCT with the fundus picture, and then they leave the hospital. And those results are monitored later on, and the report is sent to the patient. That is with the aim that they spend as less time as possible in the hospital. And that will most probably be maintained.
Thank you, Polona. I think we have very few minutes for something which has been briefly mentioned. Valentina briefly mentioned the idea of 5G remote telelasering our patient's retina. Someone mentioned the possibility of home monitoring. So very rapidly, all of you, did you put in place during the pandemic any teleconsultation possibilities for the patients, or any home monitoring possibility for the patients, starting from Daniele this time?
No, I did not. Apart from telephone contact to patient, just to keep me informed and them informed on what was going on. But I think that telemedicine is one of the things that we as a retinal community should keep from the pandemic. Yeah, with high level technology such as looking at the experiences with home monitoring, with OCT, with satellite clinics that can perform examination and send them to the clinician. Yeah.
Mm-hmm.
Antonia, what about you, Berlin, in your hospital? Any
we tried
teleconsultation?
we tried to do video consultations. However, that is so complicated because it requires a lot of time. The nurse needs to keep the patient's names and insurance companies and so on. It all takes much longer. And we're normally used to see like 250 patients a day in the outpatient department in one of the hospitals. And the problem is, if you do it with a video conference or video calls, you couldn't see nearly a tenth of these patients. So I think it's, and then with these video consultations, the problem is if the patient suddenly reports about a new appearance, if something has changed. So a video call is only good as long as the patient is doing well, or so
Yeah, I
then I
agree.
don't need it anyway.
I agree.
And if something is wrong, we have to do an exam. And then it doesn't make sense, because then you spend half an hour talking to the patient and then he needs to come back to the clinic.
Sure. So on the other side, Laurent, do you think that home monitoring via, for example, portable OCT, and we have the possibility to do that, is something valuable or not?
To detect, to screen macular edema recurrence in AMD patients or in DME patients or retinal vein occlusion patients, of course, it could be brilliant to use it. There is a huge limit. This is the price. Of course, there is the availability, but also the price. I think that in US, it's $500 per month. So it's a bigger cost. So of course it is interesting, but first we need to have them. We don't have them in France, and secondly we need money to pay them.
Sure. Bologna, do you think that this might be a good option in your country? I mean, you are living in a relatively small country, not millions and millions of inhabitants, but you also have some maybe remote areas, remote from the big hospitals where intravitreal therapies are being given. So do you think that some kind of home monitoring might be helpful in your country or not?
Oh, that's nice idea, nice device to have home monitoring. But for my country, I think that will be very limited amount of patients who can benefit from that. Because yes, that is one of rare privileges to be small. Slovenia is small, and we have 7 centers, and we have actually ophthalmologists all having OCT. And I think that majority can reach those centers or those OCT points to be monitored. But yes, there will definitely be few of them, but very limited number.
Okay, so we have a final question which I want to share. A physician is asking if we do have experience with the Notal home OCT, and I think the answer is not. We know what it is. We know the advantages and disadvantages, but I think none of us have has experience with that. So I think we are perfectly on time with the schedule. Let me thank the organizing secretariat with Peter Norris, EVEG, which hosted with this webinar, and I think all the attendees will find this recorded webinar on the website of EVEG. And finally, I want to say a big thank to all of you. It has been great to have you. Thank you for sharing your precious time and for sharing your knowledge. And hope to meet you soon, face to face, in one of our meetings. I'm really grateful to you all and for your thoughts. Obviously, very great thanks to the attendees. We had about 200 people listening to this webinar. I think this is a good result. So have a great weekend. Stay safe, At the closure of this webinar, there will be a slide for 20 seconds. And have a good evening to everybody. Thank you very much.
Thank you.
Thank you, Pablo, for
Thank you.
organizing.
Take care. Bye-bye.